Hey, hello everyone. Good morning. And welcome to the Bridging Gaps in Care. Oh, a little echoey. Maybe I could just speak like that. Okay, I will start while we figure this out. Good morning, everyone. Welcome back. The Kenda Hello? Can you hear me now? That's okay, perfect. Funded by the government of Canada's Tri-Agency at Toronto Metropolitan University. My name is Tarandi Panu. I am a tall South Asian woman with long black hair. I am wearing a teal top and checkered black and white pants. I am the strategic and EDI plus accessibility communication specialist here at the CERC in Health Equity and Community Wellbeing. It is my honor to welcome you all into this space. Before we begin, I would like to take a few moments to go over some accessibility and housekeeping notes. We understand that people may need time and space to care for themselves throughout the day. A quiet room has been set up in the Real room located upstairs on the third floor for anyone who would like to take a break. If you need assistance finding your way, please go on to our Instagram where we have links to the video or ask one of our student nursing team volunteers. They will be sitting right outside at the table. This is a space for dialogue and discussion, and we recognize that engagement looks different for everyone. Please feel free to enter and exit the room as needed. We encourage everyone to take care of yourselves and each other throughout the day. Washrooms are located right outside the hall to your left, and emergency exits are just following the stairs downstairs. You may notice our ASL interpretation team, who will be present throughout the day for those who have requested interpretation, as well as our photographer who will be moving around the space. If you have a red sticker because you would not like to be photographed, please sit to the back of the room or to the sides so that you are not documented. Once again, thank you for all for being here and for contributing to this important and timely conversation. It is now my honor to introduce Elder Joanne Dallaire, Senior Advisor for Indigenous Relations and Reconciliation at Toronto Metropolitan University, who will offer words and welcome for opening.
Good morning, everyone. Can you hear me fine?
Yes, we can.
Okay, great. It's really an honor to be here. And yes, it is a very important conversation that you're going to have today. And as been mentioned, it's really important that you take care of yourself throughout this. So I'm going to offer a prayer that's going to ground us all, hopefully, and remind us of our connection to all that is. And so here we go. Wachye, Adishna Hasan, Sahakutam, Kashishin Ishku, Mayingandodam Omashkiko. First, let us give thanks for this day and this opportunity to come together and do this good work. I ask that you watch over each of us, our families, and our loved ones. And a special shout out for anyone who's dealing with a sickness or has sickness within their family, or anyone who might be going through the grieving process. Let us give thanks to Mother Earth, Father Sky, Grandfather Sun, and Grandmother Moon for watching over us and reminding us of our bigger connection to all that is. I ask that each person here today receive something that reminds them of how important it is they are to each other, to this work, and to the world. And I say, Chimigwech, 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 aho, all my relations. Hi, hi. Thank you.
Thank you, Elder Dallaire, for your powerful and generous words. We will now offer a land acknowledgement. Toronto Metropolitan University operates within the Dish with One Spoon territory. This treaty between the Anishinaabe, Mississaugas, and the Haudenosaunee nations binds them to share the land and care for its resources in the spirit of peace, friendship, and mutual respect. Indigenous nations and peoples, as well as newcomers, have been welcomed into this treaty. The work of the CERC in health equity and community well-being takes place on traditional Indigenous territories that continue to sustain many nations today. Our research, partnerships, and community engagement depend on these lands. which provide space, sustenance, safety, and community. We are grateful for the opportunity to live, work, and learn here. Our work is long-term and community engaged in nature. Together with our partners and advisors, we aim to advance disability justice and health equity through intersectional research grounded in accessibility, care, and lived experience. We acknowledge the importance of research by, with, and for Indigenous peoples, and we are committed to building meaningful relationships with Indigenous colleagues, communities, and partners. Indigenous teachings remind us that our responsibilities are ongoing. They call on us to act with care, reciprocity, and accountability in the present. In this spirit, we offer our respect and gratitude and commit to supporting relationships and practices that uphold Indigenous sovereignty, knowledge, and futures. We also recognize that accessibility is a shared responsibility and an ongoing practice. We are committed to creating inclusive, barrier-free spaces, whether physical, digital, or relational, where diverse ways of knowing, being, and participating are respected and supported. We welcome feedback as we continue to strengthen our practices in alignment with disability justice and community care. I would like to now welcome Dean Chiaris from the Faculty of Community Services and professor in the School of Child and Youth Care.
All right. Welcome, everybody. It's a pleasure to have everybody here. I want to welcome you, first of all, on behalf of Toronto Metropolitan University. I gather that some of you are from Toronto Metropolitan University and some of you are not. So welcome to all of those who are visiting. I want to also welcome you on behalf of the Faculty of Community Services, as well as, of course, the Canada Excellence Research Chair in Health Equity and Community Wellbeing. Just a few very brief words for you. I know the program is super exciting and we want to get to it. But it does occur to me, and as I was coming here this morning, it does occur to me that we're having a symposium, discussions, conversations about health, about community in an unbelievably unhealthy world. And I think, health manifests in many different ways, but there's certainly a moment at this time that has all of us burdened, I think, by the lack of health that is surrounding us, the lack of kindness, the lack of care, the violence, the wars, and so on. And I think it's very difficult to sort of have conversations about health and health equity, access to health, and so on, without acknowledging that we're doing that in a world that is not role modeling any of these things at this moment. One does worry about the commodification of life, the dehumanization of people, the sort of lack of value that is being placed on the lives of children, of women, of seniors, of people with disabilities, of people trying to live a life. And that is a context that I think we should carry with us as we have these discussions. At the same time, I always think about health equity as being, on the one hand, about the very things that I see on these posters. I was looking at this one in particular, health equity in the context of transportation barriers, for example, and we know that there are many other kinds of barriers. And I think these are very important matters, and there is clearly some good ideas that will emerge from the day. But when I think about equity in health, and notably in health care, I also like to place some focus on the word care, which, because simply having access to the kinds of procedures, to the kinds of medical advice and so on, is not in and of itself enough. Many people gain this access while having experiences of indignities, of lack of care, of feeling isolated, of feeling diminished and invalidated in who they are as they seek care. And I think health equity really is as much about issues of access as it is also about issues of feeling humanized and validated, and really validated in one's belonging to community. I want to really thank my colleague, Karen Soldatich. I don't even know where she went. She's somewhere. As well as the team of the Canada Excellence Research Chair, which has done such an extraordinary job in really centering issues of health equity at our university, in our faculty, and in particular has done such an extraordinary job in reaching out to students who will undoubtedly become the leaders in the way in which we think about health. And that is a huge, huge contribution, I think, not only to the field of health generally, to questions of social justice, but also simply to the opportunity for students, notably graduate students, although there are many undergraduate students involved in the circle as well, to really gain those leadership skills and those insights and the critical approaches to health and well-being and community in such a good way. So a huge thank you and maybe a quick round of applause for the team at the Canada Excellence Research Chair. And with that, I'm super excited because there's about a keynote about to come up that I'm very excited about. But with that, I thank you for being here. I hope you will enjoy the day. I will be in and out a little bit as I have other things going on. But please enjoy the stay and thank you again for your presence. Thanks.
Thank you, Dean Chiaris. Is this working? Yes. Oh, just give me one moment so I can move over the slide deck. Okay, now we will move to our keynote address from Dr. Michelle Murthy. Dr. Michelle Murthy serves as the City of Toronto's Medical Officer of Health. In this role, she leads Toronto Public Health, Canada's largest local public health agency, delivering services that protect and promote the health of all who live, work, study, and play in Toronto. Please join me in welcoming Dr. Murthy.
Good morning. Thank you so much, Dean Chiaris, to Tarndeep, to Elder Dallaire for really welcoming us into this space and to today. It's really my absolute pleasure to be speaking with you today. I'm really sorry, actually, that my biggest regret about today is that I'm only able to stay for the speech and have to, unfortunately, head to City Council after this. So I won't be able to get to see all of the exciting programming that you have for the rest of the day. But we have an exciting day in council too. And I think speaking about some of the very important health issues that are facing the city today as well, just as Dean Carey was mentioning, that we have, a number of things on the docket about things that are actually not necessarily within Toronto Public Health's control, but things that we need to speak on to say, how are we improving the health and safety of lives in the city? And that's really my greatest pleasure about this position. So I started in this role in September, so just over about 7 months now. And I was also asked to speak today a little bit about my journey, because I know we do have several students in the audience that are interested in different aspects of how they can be involved in health equity and the different types of roles and the ways they can contribute to health equity work in their lives. So we'll kind of take you on a bit of a journey across all of those today. So just to start, a few declarations. I don't have any sort of personal or financial conflicts of interest to declare. I am an employee of the City of Toronto, but I am not speaking on behalf of the City of Toronto today. The remarks of today are my own. In addition to the Indigenous acknowledgement, I did also want to say that in the City of Toronto, we also have an African ancestral land acknowledgement to recognize that many people of African descent were not brought to this country voluntarily. And we do recognize the impact that's had. And the positionality statement for myself. So I am Toronto born and raised, but I have lived in a number of other countries. I've lived in the US and New Zealand, and then now back to Canada. And so I've had an interesting kind of nonlinear journey. But, sort of where I am in the story, I'm the first generation Canadian. My mother came here as a refugee from Europe, and my father came here as an immigrant from Asia. So I think very different experiences in terms of how they experienced Toronto then, and as well as how I've been able to experience Toronto growing up myself. So the things we're going to talk about today is nonlinearity and optimism, because unfortunately, I'm going to speak a lot of things that Dean Carey spoke about, some of the challenges in the world. But we're going to end on optimism, because that is my fundamental belief, that I think if we have talk about, that the only way that we are able to do health equity work is if we have optimism. And so hopefully we're going to end today. We're going to get through some difficult pieces in the middle, but hopefully we'll end on optimism, so you can see that's really the force that drives us all to do the work that we do. And I think it's really, really important to keep that grounding, because that is the energy that makes you get up in the morning and fight another day. We'll also talk a little bit about nonlinearity, because we know that we've had people from across many disciplines, across different schools, and people are interested to say, how is it that I might get into a space and being able to work in a place where I'm really tackling some of the issues of health equity. So for myself, I started actually in an undergraduate degree in engineering. So I was a biomedical engineer, and then went into medical school. I practiced as a family doctor, and then I came back and did a specialty degree in public health and preventive medicine. As I mentioned, got to work in a couple of different countries, and then before returning to Toronto. And so not necessarily a traditional career in terms of how I got to here now, but hopefully that's a bit inspiring to think about, how it is that whatever path you've been on in the past can take you and really lead you to thinking about a career in that's really rooted in health equity. So the first thing I say, seeing the diversity of the posters and the panel discussions today, the thing that I hear a lot from students is, I feel like I'm pulled in too many directions. That there's just so many issues out there. There's so many things to think about. I don't know what to focus on. I don't know what kind of, I don't want us to narrow down too early. I want to be able to be broad in my thinking. And I think that that's absolutely the right attitude to have, to stay broad, because there are so many issues. And we're going to talk about some of those issues today, that we have many, many wicked problems affecting us. And if we can't kind of keep our minds open as to how we're thinking about those, how those problems intersect, what are some of the root causes of those issues, that's the thing that's going to kind of help bring it back together and make you feel less, less torn apart, as to say, I don't want to specialize too early. But because I think that there are many things, and you're going to be able to tackle many issues over the course of your career. So this was the keep calm, carry on kind of moment, but we're gonna kind of get to the panic and freak out a little bit now, just because I think it is important to really situate where we are today, which is not a great place, right? This statement came out in a paper in 2024 around a polycrisis. So kind of coming out of the pandemic COVID, we had many global health threats, things like antimicrobial resistance, increasing impacts of climate change, geopolitical turmoil, increasing populism, global political leadership, widening economic inequities, mass displacements, converging together. And it's a term that people have called a polycrisis, to say that many, many things together are impacting the world. And this is 2024, so it doesn't even really take into account where we are now in 2026 and some of the new challenges that have come out since then. And this, again, can feel very overwhelming to think about, how are we going to possibly tackle all of these different concerns? So to layer onto that sort of list of things that we had in the polycrisis statement, and I'll also say in a polycrisis statement, it doesn't even speak to some of the underlying social and structural determinants of health that really drive the inequity of all of those issues. It doesn't speak about racism. It doesn't speak about structural injustice. So I think we also need to add to that layer of polycrisis all of the things that are our society that actually contributes to the inequity of each of those additional issues. So early in the year, kind of January, February timeline, every year, the World Economic Forum puts out what they call a global health report, a global health risk report. So this is a survey that they do amongst economists, academics, business leaders, political leaders, a wide variety of people, to say, what are your top risks now? What are the top risks you're seeing in 2 years? And what are the top risks you're going to see in 10 years? And I like to look at this because it's not from a health perspective. It's people in lots of different kinds of roles and positions. So it's not just sort of us public health people thinking about what are our current public health problems. It's actually thinking about, across a wide variety of global leaders, as to say, what are some of the key issues we need to be thinking about? So in 2026, just a couple months ago, the report came out, and the top issue was geoeconomic confrontation. Second to that, state-based armed conflict. Thirdly, extreme weather events. Fourth, societal polarization. And fifth, misinformation and disinformation. And I think that says, I hopefully that resonates for a lot of people. You know, I think that we can see this and say, yes, those are some significant challenges. This actually even came out before some of the most recent global conflicts that we've had. So you can see that further escalation of some of the issues and the risks that we're seeing now. So I think that that's, you know, again, not surprising, but it really colors how we have to think about our work. That say, you know, we can't talk about access to primary care without thinking about this in the background. We can't talk about access to better transportation without thinking about some of these things in the background. Because some of the people we're going to be seeing are very, very much affected by each of these top 5 issues. And that we need to be thinking about how we're going to be addressing each of those to make sure that when people are thinking about accessing transportation or accessing primary care, that they're going to do so in a way that makes sense for their context. It's going to respect and understand they haven't had the same experience of safety in their city. They haven't had the same experience of feeling safe to ride a bus, maybe in the countries that they've lived in. And we're not just talking about newcomers, but we're talking about a lot of other people that have had these different kinds of experiences within their current context. So some of the other interesting findings in the report was even looking at some of those longer term projections. Where are we going in the next 2 years and the next 10 years in terms of these global risks that we need to be thinking about? So in the next 2 years, that geoeconomic competition still stayed quite at the top in terms of, you know, some of the real challenges that we're going to see, I think, in terms of increasing tariffs, increasing costs, increasing like very rapidly rising inflation. That's going to put it a damper, right? We know that you know, health in itself is around over 40% of the provincial budget, certainly, and costs continue to increase. So we're going to have very constrained budgets and impacts over the next couple of years in thinking about that kind of context. But the 2 years too, like what comes up really interesting is that misinformation and disinformation. So that is, you know, something that economists and business leaders are talking about and thinking about, that has an impact on a real risk for us in terms of our safety and our security in the world. And I'm sure many of you are probably, you know, still learning. We're all still learning about how to use AI effectively, how to incorporate that into our work, into you know, making sure we're using this as an appropriate tool. But we also know the significant risks associated with AI. We know that there's huge, you know, structural bias in terms of the data that's being used, and so sometimes some of the answers don't actually provide us with the right information, or might have very gendered, very racially biased, or other biased results that we're seeing. What we do see in that longer term horizon is actually a shift. So all of these sort of more human-made issues, top 3 issues, have actually given way in that 10-year risk. So the thing we have to still keep very much an eye on is the global and climate change risk. The top 3 issues the next 10 years: extreme weather, biodiversity loss, and critical changes to the Earth system. So as much as we're thinking about all of our interactional ways that we are working internationally, multinationally, the way that we interact with people and society, we also need to think about our relationship to the Earth, our relationship to how we are preserving the climate, how we're adapting, becoming more resilient, and improving our technology so that we're not contributing to climate change in the same way. And I think really, you know, the kind of nonlinear area I wanted to raise in this is just how rapidly sometimes these risks change. So if you look at the same report from last year, beginning of 2025, geoeconomic confrontation was number 9 on the list. And then in 1 year, it jumped to number 1, and very clearly number 1 risk. So you can see that, you know, even just in the context of a year, that's a very nonlinear risk progression, right? Most other things were kind of in and around the same level of what we saw before. But that's one of the ones where something can happen in the world where you see a very rapid change, and we need to be adaptive and responsive to those kinds of rapid changes in context, because they are going to have really meaningful impacts in the work that we do every day. So this is my last one from the slide. I know it's kind of tiny. Do encourage you to take a look at this report yourself. But they also kind of always put together this web of the intersecting nodes of risks and their influence on each other's. And even though it's a bit of a kind of messy web to look at, why I like it is because they've, you know, for the last couple of years now, the biggest node that has the most impact on all of the other risks is inequality. You can see that right in the center. And one of the second other biggest ones is that decline in health and well-being. I think really centering to say, all of these other risks, we probably can manage in different ways. But the thing that's really going to drive the outcomes of those risks is really centered in our inequality and the health and well-being of our people. Because without either of those things, we can't really move forward. We can't, if people are not well, we don't have an army to be able to send for an armed conflict. If there's inequality, we can't really address some of the challenges that we're seeing in some of the other risks. So I think it's really great to be able to kind of see that as a risk and then have a session like today where we're actually talking about that. We're saying, how do we think about health equity? How do we think about inequalities in our life? So that really center that and focus it on the work that we do every day. But why else is inequality such an impact? So certainly this is our own data from Toronto Public Health. We do look at we did a 10-year report on mortality, specifically mortality in Toronto. And we look at all-cause mortality age standardized by income quintile in Toronto. And it's done, we had the comparison because we last did this analysis 2014 to the most recent year's data would be 2023. And we can see a very specific gradient. In the lowest income quintiles, there's the highest age standard rate of mortality. In the highest income quintile, there is the lowest rate of mortality. And it's a pretty linear gradient across those quintiles. And it hasn't changed. 2014, I mean, the overall rates have come down across all age group, all quintiles between 2014 and 2023. People are living longer than they were in 2014 because of lots of other reasons. But that gradient has not changed. We still see a very distinct separation in terms of how long people are living based on income. And we can see it even more specifically when we look at some of the maps of Toronto. So we can see that the darkest blue maps there are some of the highest age standardized mortality, so the highest rates of dying in those darker blue ones, and the yellow is the lowest. And some of the neighborhoods, if you're familiar with Toronto, if you kind of grew up here, I don't think some of those neighborhoods would surprise you, some of the challenges that we see there. But I think what sometimes is surprising for people is the juxtaposition between some of these areas. If you look right in the center there, there's two neighborhoods that are dark blue, and right beside them are red yellow. So we have, one side of the street has some of the highest mortality, and one side of the street has some of the lowest mortality. And we see that very much in parts of the city. And that's something that if you're living in that wrong side of that street and you're able to look across and see the better side of the street, and they have more parks and they have more green space and they have fancier houses than where you're living, and knowing that you're going to have a lower mortality because of where you're living. So I think that stark reality is really present in here, and then we're trying to understand how can we continue to show this. We showed this data 2014. We show the data again for 2023. We don't want to show it again for the next 2035 data to say this is again happening and we still haven't addressed any of those issues. We need to start thinking about how to really change that mortality trajectory. And some of the challenge in that inequality is very stark. So as part of this, we also look at deaths amongst people experiencing homelessness in Toronto. And our most recent year of data in 2024 looked at the median age by females and males, as well as overall. 2024, the median age of deaths amongst women or females who were experiencing homelessness was 38. 38. Whereas for the rest of Toronto, the median age was 85. That's, close to a 50-year gap difference in terms of people and where they're dying. And that's a very gendered specific. I mean, we see certainly a very large gap for males as well, but a very, very stark contrast. And we also can see this gendered inequality just based on why people are dying. And one of the most common reasons for females, about 2/3 are related to the acute drug toxicity crisis. It's about half for males, and we can see that other half is contributing to why some males who are experiencing homelessness have a longer lifespan compared to females, but very, very much impacted by the acute drug toxicity crisis. So we know that inequality is at the center of each of these. We know that there are very systemic social and structural determinants of health, why these are happening. So how can we have any agency and influence? How can we actually start to think about something so complex and so stark as this and think about how we might be able to make a change? And I think the first thing we need to think about is how we can be influential in that political process, in our societal process, in our civic dialogue process. And so one of the other kind of key reports I tend to look at the beginning of the year that comes out annually is the Edelman Trust Barometer. And this is, again, another survey that's done to look at how people trust and what do they put their trust in. Because certainly if we're going to try to adjust how people are thinking about it, we need to know how to communicate with people. I would kind of venture to say today, the kind of conversations you're going to be having with each other are going to be at a very higher level academic setting. You're going to be having, mature conversations and have a respectful civil discourse as to differing opinions as to what will be happening. We're not going to have a lot necessarily of dissenting opinions potentially. And that can be a problem. We want to have dissenting opinions. If we don't think about hearing from people who don't sound like us or don't look like us or have very different ideas than us, then that can impede our ability to communicate with other people. That can impede our ability to have a different idea about things. That can impede our ability to actually connect with people and make sure that they understand, true facts and health information in a way that's actually going to change people's minds. So I think it all starts with trust, and we absolutely saw this during COVID. One of the key issues around COVID was how well did countries do based on trust. Canada did actually very well. I mean, compared to globally, Canadians actually have a very high level of trust overall compared to some other countries. But we know that got fractured and that definitely worsened during the course of the pandemic. We also know that it's again income divided. People higher income versus lower income. People at higher income have generally a higher level of trust in public business entities, governments, whereas people with lower income have a lower level of trust. So in general, our ability to communicate and be effectively communicating and have trust with people at lower income is very different. And so we need to have, again, a different way of connecting with people because these usual methods are not going to work in the same way. We also know that global challenge that we saw in that risk report has an impact on our ability to communicate and that trust factor. We see that these sort of bigger macro influences, things like cost of living, discrimination, misinformation, contribute to that polarization. That makes people become more insular because they now believe that there are major divisions within a country. We know that there's a grievance to now feel that people feel like that system is rigged against you, that people in power don't believe the same things I do, and I don't trust them about that, and leads furthering to that insular knowledge. And we also see that gets amplified in things like social media and through AI algorithms, because the more that you look at specific news or specific types of clips, then that's what it's going to feed you more. And so you could become very narrow in the types of information that you're getting based on what you're looking at online. And that's very much engineered to have that purpose. So that siloing of what you believe in will become very different over time. And your recognition that other people might believe different things than you do goes away because you only see the same thing that you believe in. You're not seeing that alternate opinion. And so we can see some of the impact of that. So 7 in 10 Canadians now have more of an insular mindset because of all of that pressure and that sort of scope of what's driving that insularity. It means that people are going to be less likely to trust someone else who has a different set of core values, who believes in different facts, who believes in different sources, who wants to address societal problems differently or have different culture, background, and lifestyle. And so we see this in many different things. I think COVID example, like vaccines. So we know that some people have very specific opinions about vaccines, and it's hard to penetrate. But the people who kind of have these, ideas don't want to hear about other ones. People who very much believe in vaccines can't really get into the mindset of somebody who doesn't believe in vaccines. And I think that's a challenge. It's a challenge we even see in public because we're trying to communicate with everybody, whether you're going to believe in it or not. But if we can't find a way to talk about it without them shutting off, then we'd have no communication. We can't penetrate. We can't actually have any kind of dialogue as to say what's going to make a difference. And you know, I find it interesting. So I'm obviously a vaccine advocate. I believe in vaccines. That is our kind of bread and butter of public health and things that we do. But my mother is, I would say, a vaccine hesitant person. She, and you know, rightfully so. She's had anaphylaxis to multiple vaccines over time. And she actually had, from the first COVID shot, she got anaphylaxis. She had to have an EpiPen. She was okay. But she was so determined to travel. She said, I'm still going to get the second shot. Even though we told her, no, I don't think it's a good idea. Really, you know, you kind of ended up in hospital the first time. She's like, no. If I don't get the second one, I'm not going to be able to travel. So she like dosed herself up on all these antihistamines. She had her EpiPen ready. She went to the pharmacy. She got her second shot just to do that. But she was, you know, very like, the only reason that she was going to do it was because of this outcome, that she wouldn't be able to travel if she didn't have it. And so for lots of other shots, she's hesitant. And I understand why she's hesitant, right? Nobody wants to think about having to go and have anaphylaxis after a vaccine, if that's been your experience over time. But again, you know, I can talk to her because she's my mother, but you know, we don't always have that same relationship with all the people that we interact with. And so, you know, knowing sometimes a story about why is somebody hesitant about a vaccine is really the thing that kind of helps us break down that barrier in dialogue. And it's not just like, you should get it, no, I don't want it, and then that's the end of the story. So we see that trust gap is changing. You know, people, again, we saw that people with a more open mindset are more willing to trust people, even if they are from a different background. So if you have that more open mindset, even if, you know, someone's not like you might be able to believe in them. So you're saying, you know, I'm a staunch liberal. I'm going to still listen to a PC leader just because, you know, I have that more open mindset. But people with a more insular mindset, which is now 7/10 of the country, are saying, no, you know, I'm not going to listen to somebody. I'm a, you know, strong PC, liberals in power. I'm not going to listen to them because they're not like me. They're not thinking like me. And that's a challenge, right? Because you know, most of our elections are pretty close for like, you know, kind of 50-50. We've had a minority government for a while now. That if half the country doesn't believe in the people who are in power, then that's a challenge, right? We don't have a civil diagnosis. We can't really move things forward because people are not going to be willing to listen to other perspectives. What we do see, though, interestingly, is because of this insular mindset, some of the most influential people in that blue bar, 66%, said they trust their neighbors. How many people know their neighbors? Some people, not everybody. But that becomes the most influential people. And when I think like people they mean by my neighbors, they mean like people you're close to, right? Like your friends, your family, the people that you interact with on a regular basis. And so that means we each have a very specific reason to be influential in our spheres of influence. That we need to be able to talk to the people that we interact with on a regular basis about lots of health issues in a way that's going to drive sort of forward that civil discourse, because that's who's influential. So if I have a friend, a neighbor who is very anti-vaccine, it's my responsibility now to kind of open that dialogue with them, because they're going to now listen to me in a way that's different than listening to me as a medical officer of health, because they're not going to listen to me because of medical health. We see that government leaders only 44. So probably, you know, public health is maybe a little bit higher than that, but less than their neighbor. So I have to now interact with people because they're my neighbor, because they're a fellow citizen, because they're a fellow Torontonian, because that we have to kind of connect on a different level that's going to be meaningful to them in a way that isn't meaningful clearly when government speaks or when CEOs. And I think one of the most interesting kind of takeaways from this year's one was around, you know, how we're doing to fulfill that role in brokering trust. So some of the advice that was given in this, and so people, again, sort of voted for different things that both NGOs, governments, and media can be doing better to try to kind of facilitate this trust building between distrusting groups. So things like NGOs, like how do we have them help broker more conversations? Things like local community mediation programs, things like dialogues where people can kind of help understand each other. What's that perspective? How do they have that, promote that civil discourse in a community setting? And similarly with governments, right? How do we ensure that our politicians are going to be engaging in civil discourse? I tell you, I'm heading to City Hall later today. It's not always a civil discourse, right? We know people are very much going to be promoting their decisions. We do have, you know, Robert's rules and lots of orders process. I think overall, compared to lots of other countries, it's still a very civil process. in terms of how we actually debate and dialogue on different issues. But I think we could do better, right? Like we can hear other people's opinions in a different way that's more about the issue and less about the person or the kind of angle that they're coming from. And the media, I think, has to do a better job, right? Like they're asking the media to say, you know, please write more accurate headlines. Like, don't be so sensational. Like, you know, we can see so people will get very clouded and that polarization of different media and feeling like people aren't using traditional media. Well, we know that, and we know that's a significant issue because people are kind of turning to YouTube clips or other, you know, social media to be able to hear that information. So we're not seeing that time. And we also, again, we don't see that equal time and coverage to really presenting a more balanced opinion on some of these issues. And so I think that's kind of the call to action, say, you know, how do we really ensure that we are looking at things from both sides and presenting that fairly? So trust to influence health. So we kind of heard about lots of macro problems. We heard about some advice about to say, you know, we know kind of the issues around communication, the things that we need to do to be able to have more influence and trust in terms of the people we're working with. But what are some of the challenges that we need to apply that to going forward? And why is this so important to like think about some of these ways of doing it? So we're in climate change. You know, we've talked about lots of things. So this one of we saw that 10-year risk, top 3 risks in that kind of future time horizon were all climate related. We already see it now in terms of lots of impacts related to climate change in our kind of current environment. We know we've heard this year is supposed to be another El Nino year. So again, you know, hotter, drier summers, more risk of wildfires, more risk of displacement due to those issues. And then again, you know, secondary impacts on growing, cost of food, when at a time when we're also already having other impacts of affordability. So lots of immediate as well as secondary impacts of climate change that we need to really be thinking about. And I think there's a balance here. You know, certainly in my role, kind of one of the clear issues about climate change we need to focus on is adaptation. You know, there's lots of other people who are really thinking about some of the other solutions. My kind of day-to-day role is how do we get better flood protection? How do we make sure that, you know, roads and TTCs are still working so that people can still manage and get to their office or school on time when we have those kinds of issues? How are we protecting people against some of the emerging infectious diseases like West Nile virus and other tick-borne infections that are happening more so because of climate change? And I think we need to think about that resiliency because that's the thing that'll kind of drive the innovation to be able to make more adaptive. We know about emerging, re-emerging infectious diseases. So obviously, pandemic was a big, you know, impact to our lives. I think everyone sort of had lots of their own experiences, you know, during that pandemic period. But even kind of coming out of that, we've seen lots of other emerging and as well as re-emerging infectious diseases that are having an outsized impact. So in Ontario last year, in 2025, there were over 2,000 cases of measles infection in the province. That is more than we've had in the last multiple decades in the province. Fortunately, Toronto only had 10 cases, knock on wood, and thank you very much to our staff who contributed to that low rate for Ontario, for Toronto. But 2,000 across this, right now, there's 3,000 cases that have happened in Manitoba. And if you think about, or 300 cases in Manitoba, if you think of that sort of per population, 300 cases would be over 3,000 cases in Ontario. So we know that this is still an ongoing issue. It's something that should not even be happening, right? We have very good vaccines. We should have universal coverage of protection against measles. That should not be happening. Yesterday, March 24th, was World TB Day. I don't know if people had any participations in World Tuberculosis Day. Tuberculosis is one of the oldest infections that we know about in the world. You know, mummies from ancient Egypt were found to have had TB infections in their mummified bodies. So this is something that's been with us for thousands and thousands of years, and we still haven't gotten rid of it. And we still have very old medications to treat it. And we still have lots of societal prejudice against people infected with TB. And so we still have a lot of work to be doing, things that are both old as well as new infections. We still don't know what's that next pandemic, right? You know, we've had certainly the level of pandemic we had with COVID, hopefully not going to happen for a while, but we're going to have another kind of pandemic at some point. You know, 2009, we had H1N1, 2003, we had SARS-1. You know, we're on a cadence that another pandemic is very likely. So mental health and substance use. I think we already kind of talked about some of these very, very specific issues around some of the impacts of substance use in the city. Certainly we spend a lot of time talking about the opioid and the drugs toxicity crisis. But, I think a couple of things that we don't pay enough attention to and that we're really trying to leaning in on is the outsized impact of alcohol. So if you look at total cost of alcohol, far outweighs any other substance, $7 billion in cost in Ontario, based on an estimate from 2020. Total cost from tobacco is certainly very high, but we know that number is continuing to come down as we see less and less smoking in the population. But the thing that's continuing is that outsized impact of alcohol. There's a very important piece of legislation in the Senate. Hopefully we'll get forwarded to the House of Commons to move forward on alcohol labeling, to actually have warning labels on alcohol to say, this is a carcinogen. We don't have that. We have very, very good packaging information on tobacco and cigarettes to say this, all the different pictures of very scary cancers on tobacco cigarettes. There was no warning on alcohol to say this is a known carcinogen of 7 different types of cancer. And most people do not know that. Mental health as well, component of this. So recently, Toronto Public Health is part of a group called Thrive Toronto. That's with CAMH, WellBe Institute, a number of institutions, and put out a report card earlier this year looking at mental health in the city. And certainly equity-driven communities really sort of came out in that as sort of perceiving and experiencing their health and well-being very different compared to other groups. And so we know, again, we have a lot of work to do with specific ways that we're approaching mental health in the city, but this can't be a one-size-fits-all. We need to have very specific types of ways of reaching and providing mental health services for different populations. Food insecurity. I think that I saw some presentations, coming to today, thinking about this issue. Certainly in our affordability crisis, we have seen the shift. In 2019, it was 1 in 6 households in Ontario were food insecure, and that's changed in 2023 to be 1 in 4. And that's true in Toronto, 1 in 4 households are considered food insecure. And we've seen increasing demands on things like food banks, which is not a sustainable solution, and also not an appropriate solution for long-term food security. So again, wicked problems, many different issues, many different answers about how we're going to be able to address this. And we need lots of diverse brains to think about it. It cannot just be, public health thinking about this. This cannot be, government thinking about this. This needs to be very much community and society-wide ways that we're thinking about each of these issues, because that's who's impacted. If it's our community that's impacted, then the solutions have to come up from the community in partnership with all of those other layers who have more of the tools to be able to actually try to influence change on some of these areas. Okay, so optimism. I said we were going to get to optimism. I think we talked a lot of the, panic and freak out kind of issues, but I think we wanted to kind of end on say, hopefully the inspiration for some of those issues was to start thinking about, yes, there are wicked problems out there. There are lots of things for you to put your mind and energy to say, how can we be improving the health equity in our province? How can we help improve health and well-being in the places that you work and study as well? And so why do we actually need optimism? So not everyone is an optimistic person. We'll just say that, people have different personalities. Some people are half glass full, some people are half glass empty, some people are, it's exactly 50-50. It's okay. You don't all have to be individually optimistic. Although if you are an individually optimistic person, studies do show that you do live longer. So we've had lots of studies to show that, women have less risk of heart disease, stroke, and longer life if you are by nature an optimistic person. So if you are not one, you could try to cultivate a sense of optimism in yourself, because I think that is a thing that's going to help bring it forward. But the work we do is fundamentally optimistic, right? So certainly in public health, we talk ourselves as being at that sort of primordial and primary prevention part of upstream work that we do. And prevention is being optimistic, because prevention means we're trying to intervene in a disease to alter the course of the disease. We're not just going to say, oh, you've had TB, you're going to die of that, right? We're going to say, oh, you've had TB, we can treat you, we can provide other supports for you, we're going to alter your course so that you're not going to have that bad outcome. So that's being optimistic and saying, you know what, we're not going to let this bad thing happen to you because we can do something about it. Innovation is being optimistic. And a lot of the work that you're doing, as academics should, is contributing to innovation. Science, technology, research is all about thinking about how to bring about a different solution to something. So that's fundamentally optimistic because you are thinking about new ways of doing something to get to a better outcome. And so kind of keeping that faith in that, yes, we can find a solution to things is being optimistic. Acknowledging achievements is being optimistic. And I think this is something we don't always do enough. Especially I think there's, hopefully some prizes and awards today to kind of recognize the achievements we have. We're hosting coming up later in April, the Toronto Community Champions Awards, which recognizes different community agencies across the city who are doing really outstanding work. Being able to do that kind of recognition of achievement is being optimistic. It's saying, look at how far we've come. Look at the things that we've been able to do. Yes, there's going to be setbacks. Yes, it's not perfect, but we do see that innovation. We do see that implementation of things that are making ourselves better, our lives better. And lastly, collaborating is being optimistic, right? That believing that as a collective, I'm not smart enough to solve this problem, you're not smart enough to solve this problem, but if we're all working together, we can probably put our heads together and come up with a better solution to something that's very difficult to address. And so that collaboration is being optimistic. Because it's saying we understand the power of collective thinking, we understand the power of using other people's ideas. We understand that power of civil discourse to kind of bring together diverse opinions to lead to a better outcome. So it is necessary to be optimistic, even if you're not individually optimistic. We also know we have to be optimistic because change can take time. So this is a graph of smoking prevalence in Ontario. So if you're looking back kind of at the turn of the century around 2000, we were still up over 23% of the population was smoking. Fast forward 20 years to 2020, we're down now to 10%. So over a 10% drop in a 2-decade time frame. For people working in the smoking field, this felt like glacial pace, right? Like if you're every day, you're trying to get people to reduce smoking, 20 years is a career's worth of working on anti-smoking. But in that same time, think about that, what you achieved. You went from like halving the prevalence of smoking. So that's, now like that 12% of people who would have had all of that $4 billion of outcomes related to tobacco are now not going to have those outcomes because we've been able to do this trajectory. But it's going to take that optimism to say, yes, we're going to, it's going to take time. So I think we're in that same trajectory for alcohol right now. We're kind of at a turning point where people are recognizing, very different kinds of harms associated with alcohol. Hopefully it doesn't take us 20 years to get there. Hopefully we're going to learn from the experience of tobacco, but we still have to be optimistic that we are going to get there. We're going to achieve those gains in the end. Being optimistic is also thinking about how we can be collaborative, adaptive, responsive, right? We saw how rapidly things change, that geoeconomic risk going from 9 to number 1 top risk in just a year's time. We have to be adaptive to changing things. And it also means optimistic saying, we're not going to get things perfect the first time, but we can do better. We want to go from, good, better, best, and we're not always going to be at best, but we can always be aiming to get better and to get to best. And these examples are in the picture. So that first one on the left is a picture of the mass vaccination site that Toronto Public Health ran during COVID. And it was one of the first ones, everyone was very excited. We had lineups out the door. People wanted to get vaccinated. We had to use very large centers like, the Better Living Center to kind of have these mass clinics where we kind of were doing things. But as we start those up and we're trying to do that volume, we realized we're not reaching everybody. And very specifically, we knew we weren't reaching people with disabilities. And we weren't reaching necessarily Black community. We weren't reaching people in Scarborough and in Etobicoke. And so we had a lot of work to do to think about how do we actually adapt the kinds of work that we were doing at the beginning, which was good. We were doing great things. We were seeing lots of, thousands of people are getting vaccinated every day. But we needed to improve. We needed to get better. We needed to have a table where we were hearing from people with disabilities and say, what are your challenges? People needed to come and tell us, like, actually, that civic center that you ran doesn't have a working elevator, so I couldn't get to the floor to get my shot. Or, people needed a quiet space that wasn't just sitting with thousands of other people or hundreds of other people after the vaccine because their, anxiety or other neurodivergence made them feel like that wasn't going to be a comfortable space. So how can we have comfortable spaces, like quiet spaces for people to be after? How do we have, more interpretation or people who speak other languages, or how do we have that more welcoming space? So, we can see some of the dates. We're kind of early, the earliest, when vaccine became available wasn't until like July and, like many months later that people were now having this more adaptive life. So again, we weren't perfect at that start, but we had to have that optimism that we were going to do better. And now that we've learned these issues, we know we're better for next time. So we had to do this again. We would know from the start, yes, we need to be able to adapt and have a better approach to doing this work. This is a report from the previous Chief Public Health Officer for Canada, Dr. Theresa Tam. One of her last reports before leaving that post was on working together to thrive, well-being and public health. And I think that this was her sort of optimistic send-off swan song report, because it really talked about a new vision for thinking about health. So many of the other reports that we do in public health are about bad things, right? We're drinking too much, we're smoking too much, we're too diabetes is too high, smoking too high, all these things. But this was actually trying to reframe it to say, let's have a more positive vision for health and well-being. Let's get to those asset-based indicators as opposed to just deficit-based indicators to say, let's measure not just what's wrong with communities, but what's right about them. What's that resilience that we see in people, in communities, in our society that we can measure and actually amplify and share and say, are other people thinking about these things, how to make ourselves more healthy and resilient? Thinking about the partnerships that we need to be able to do that and really focusing on those deficits from a perspective of reducing disparities. We're not just going to call out deficits, but really actually only calling it out if we have a solution to be able to say, how can we address that? How can we make that better? How do we lift up all boats? So what's next? Again, I was asked to speak about to kind of give you some thoughts about, how do we center health equity, no matter what kind of career you might have after you finish your studies and through your life, because you're probably not going to just have one job or career over your lifetime. You're going to have lots of different roles that you're going to have. So how do you kind of really anchor that lens of health equity within that space? And I think it is a lens, right? Like health equity is not a job title. We actually do at Toronto Public Health do have a title that's health equity manager and health equity promoters, but those are 3 people in our organization. Whereas I would posit to say all 1,800 people in our organization think about health equity on a daily basis, even if that's not in their job title, because that is just the work that we do every day. And so whether you're in communications, whether you're part of our fleet courier services, whether you're in our dental clinic, whether you are health equity manager, this is the work that we think about on a regular basis. And again, it's not even just to be public health. So I was kind of curious because, misinformation, disinformation was so prevalent as a risk. So we have Copilot. So I use Copilot. And I said, Copilot, can you give me a picture what health equity looks like? And the first one that came up was the one on the left. So this is Copilot AI's idea of health equity. That is sort of this, I don't know what the scales are supposed to represent, about the equity justice piece, but they gave a doctor, a public health person, an advocate, and government. So this range of people, and this is it, right? These are all the people working in health equity, apparently, according to AI. And we know that's not true, right? We know so many different kinds of roles. There's so many different types of opportunities that people have to be able to contribute to health equity. These might be some of the more traditional functions for sure, but certainly not barely even scratching the surface of all the ways that we can be contributing to that. But I mean, I think, those some nice things that AI did. Well, they sort of showed a bit of a gender balance. They showed some racial diversity. Ages are all about the same. We don't really see a lot of younger people or older people. So I definitely think AI can do better in terms of that. I didn't give it a lot of prompts. So just to kind of say, this was a very basic prompt that we kind of gave them, but that's what it came out with initially. So I tried again. I said, okay, AI, now give me, what is health equity in a community look like? And it gave me the second picture. Actually, the first version of the second picture, it had the person in the white coat and stethoscope as a man. So the only white person in the photo was the white male doctor, and then racialized other folks. I don't know. I'm not actually sure what that older gentleman is. There's also this weird thing in the background. There's sort of somebody sitting at a desk in the middle of the park. You can see that. I don't know if that's a hallucination or what they're thinking, what that represents. If there's somebody in the middle of a park working on something, but they could have put the hospital as a center there, some houses, some buildings, park, green space. So I think some nice things about this. It's about different generations this time. We sort of see a bit more of a lifespan approach. I did reprompt it to say, can you change the man in the white coat to a woman? And so it gave one, but it still gave it as a white woman, not a racialized person. So that's sort of the only sort of professional in that photo. People are contributing to the environment. We know, that there's the places and spaces we live have such an impact on our lives. So kind of nice that they're planting a tree, they're being hopeful for the future. It's in this nice park setting. But there's not a lot of the other things that like we would think about in a healthy city, right? We don't see a bus to take people and have really accessible conversation, transport. We're not seeing a bike lane or somebody riding a bike. Maybe instead of that person at a desk, it could have been somebody riding a bike in the background to kind of talk about accessible ways of moving about the city. So, I think again, it shows us we're definitely at the good, not at the better or the best in terms of where we need to be thinking about this. But I think that's where you all fit in, right? AI is at a very early learning stage. We need to give it way more content to be able to learn from, because that's how AI learns, is to have actual content that's out there that talks about people like you in leadership positions, people like you driving the health equity work that's happening every day, people like you that really shows what are the different elements of a community that makes it healthy and well. And then hopefully when I kind of rerun this prompt in a year from now, maybe we'll get a little bit of a better, more inclusive picture to think about what is health equity and what does a thriving community look like. So thank you so much for the time today. It's been really my pleasure to speak to you. I have a few minutes for questions, but I really do wish you all the best for the rest of the day. And thank you so much for hosting me.
Does anyone in the audience have a quick question? Oh, yes. Bottom.
I'm not sure exactly what we mean by private. I mean, I think we do have a lot of partnerships citywide. They're both private with government types of resources. So I think, one example that we have of that is the student nutrition program. So the student nutrition program is a program that Toronto Public Health helps deliver that provides a meal to all school-age children. It is mainly government funded. So we have funding at the city level, federal level, as well as provincial level. But it's always been designed to have some, one community level involvement. So a big part of it is like parents and communities volunteering to help deliver the program, as well as other local businesses who help contribute, whether not for profit or for profit ways to that program as well. And we actually are just announcing later today at the City of Toronto that we have a grant from Bloomberg Foundation to look at ways of including more local businesses within this model, to say, how can we have local businesses who are helping to deliver the food? How can we have more local providers of that food to be part of that partnership as well, so that we have the grant funding as well as that kind of very local partnership, as well as private partnership, to be able to help provide the food in as cost effective as way as possible and reaching all children. Oh, okay, where do you want to go? I think went first there, and then yeah. We do. I mean, so during COVID, it was much more active for sure. We had a disability action table that was helping to provide things like advice on how do we run the vaccine clinics better. Um, it's become a bit more quiescent certainly since COVID, but I don't think it's gone away, and I think it is definitely something we're working on to try to reinvigorate and make sure that we have that representation, that regular place that we can go to get advice around a broad range of disability issues in the city as well. One final question. Yeah, no, thank you. I think that's a really, really great point. Certainly, we know from things like the street needs assessment, lots of other counts of people who are homeless, 2S LGBTQI plus is vastly overrepresented. We know trans queer youth are vastly overrepresented in homelessness surveys. So uh, we we do collect that data in terms of where it's available. So some of this is based on how it's reported, if it is available. Unfortunately, in terms of the deaths, it's the numbers are very small, and we have sort of a small cell count problem. So we're not always able to provide that publicly because the numbers are small. But we definitely do try to have it, and I think I mean, I think it's knock on wood, a good thing that the numbers are still small in that regard. But certainly if we could provide it, and if there's other ways that you're looking at research or that if we can kind of work more directly with partners to be able to provide that data where it's available in that breakdown.
Thank you, Dr. Murthy. Hope we can get a right on plot. Okay, thank you, everyone. A lot of the issues that Dr. Murthy brought up, we at the Circ and Health Equity and our partners talk about on the daily. It's something that you can see through our projects, follow us on social media. If you go on our website, you can see the active nature of our projects and who our researchers are. And I really do suggest that most of you do. And as we engage with you, we would love for you to engage back with us. So now we encourage you to take a moment to review the programs on your table and plan for which panels you would like to attend. There will be 3 concurrent panels from 11 a.m. to 12:30, followed by another 3 in the afternoon from 1:10 to 2:40. This will then be followed by a poster session starting at 2:40 with some time to move around, along with a coffee and tea break leading to our professional panel at 3:30 p.m., featuring representatives from Casey House, CAMH, and Unity Health Toronto. We would also like to remind everyone that the best oral presentation will be awarded a $500 honorarium, along with support for publication, and the best poster will receive a $300 honorarium award. Voting will take place at the end of each panel. You can access the voting forms using the QR codes provided on the program. If you have difficulty, please find one of our staff members. Staff members, can you please raise your hand? And student staff members who are at the back of the room. We can provide help scanning the QR code to help you vote. Moderators will remind you to vote at the end of each session, and results will be announced during the closing remarks. So the time is 10:13, and we will now take a brief break. There is tea and coffee at the back of the room, and the panel presentations will start promptly at 11 a.m. Thank you, and please enjoy the rest of the day.